Welcome to all of you, and thank you for joining us this morning. We are going to start with the president of the Global Virus Network, Dr. Christian Brechot, who will provide a summary of this year's annual meeting. In addition to Dr. Brechot's role at GVN, he is currently the Senior Associate Dean for Research in Global Affairs at the University of South Florida. His career highlights include serving as the General Director of INSERM, the French National Agency for Biomedical Research, and Vice President of Medical and Scientific Affairs at Institut Mérieux. He also served as president of the prestigious Institut Pasteur, including the coordination of its research programs throughout the world. Dr. Brechot will be joined by the following experts for the Q&A session, who are all leaders of GVN Centers of Excellence. Dr. Lin-Fa Wang of Duke Medical School in Singapore, Dr. Konstantin Chumakov, FDA Office of Vaccines Research and Review in the United States, Dr. Ab Osterhaus of the TU Hanover, Germany, Dr. Johan Netz, Rega Institute of Belgium, and Dr. Raymond Shanazi of Emory University here in the United States. Following Dr. Brechot's comments, please, or during his comments, you can submit questions in the question box on this call, or you may also submit questions via email to the following address: gvn-svc@sardverb.com. That's SARDVERB. And we do ask that if you're a member of the media, you identify your outlet. So Dr. Brechot, over to you.
Thank you very much, Lisa, and welcome to everybody to this press conference. As Lisa has introduced, I will give a short introduction to what is the Global Virus Network and a short summary of this very interesting workshop that we had the past 2 days, and then we will have questions and answers. So the Global Virus Network has been created by Bob Gallo and Billy Hall a few years ago with the idea that in addition to the research agencies, to the existing international institutions, we really need to merge the bright minds. We really need to merge the best experts in virology worldwide. So this is really a science-driven and an independent network. And these are extremely important words nowadays. We have now 57 centers of excellence worldwide disseminated throughout the world and 11 affiliates. And schematically, the activities are scientific projects. We also have task force, obviously a task force on COVID-19, and this is a topic today. But I just want to remind you that the Global Virus Network is working on all human viruses. And we had task force on Zika, on chikungunya virus, but also on HTLV1. It's about education and training the next generation of virologists is a key point for the future of the control of pandemics. And actually, it has been my experience and actually the overall experience that we have a shortage, clearly, of virologists worldwide. So we have education, mentoring, we are creating a GVN Academy. We have advocacy. If you are interested on the website, we have statements, perspective, educational documents. And finally, this is about expertise. And expertise is at the heart of what we can provide, because this is, again, science-driven and independent expertise. And this is extremely important for international, national institutions, also industrial partners. And from its inspection, the GVN has been very much focused on the connection between academics and industrial partners. So the context of the annual meeting, we all know it. We are in the midst of a pandemic. A single virus has simply overhauled the whole planet with major economic, but social, psychological impact, obviously impact on health. But this is not only the death rates. It's about those people who are sick. It's about also the sequelae the long-term follow-up of those individuals with COVID-19, and this has been discussed during the meeting. For example, I remind you that at 3 months, for those who had symptoms, at least 30 to 40% of the individuals have still short breath and have still some remnant, I would say, of the infections. So we have to, one of the conclusions of the workshop before going to more specifics is that we have to remain humble. We have to acknowledge that there are many things that we just do not know. We really believe that eradication will not be possible. We really believe that herd immunity may never be reached, but we don't know what the future holds. For example, the SARS-CoV-1 epidemics has disappeared. Exactly why has not been fully clear. So we may have persistence of this for a long term. We may have seasonal variations. We may have a slowdown. We don't know, but we have to prepare. And we need to live with these virus. So the aim of the meeting has really been, and this is very timely, to take the opportunity of the annual meeting of the GVN and ask what went wrong in the way we have handled this crisis. What has been properly handled? Which are the challenges ahead? Which are the recommendations we can make? And again, by a group of experts who are science-driven, who are independent, who are international. So the first topic, and completely online with what I just said, is preparedness. We must recognize that following the pandemics, HIV, influenza, Ebola, and many others, a lot of progress has been made in global and One Health over the past years. But at the end of the day, the truth is that we were not ready. And so we have, the workshop has been devoted for the first session as to sharing different experience from different countries and really delineating how we could do better. So it's really about cooperation, but also coordination of the different efforts. It's about multidisciplinarity. You see, this is something that which had already been recognized, but maybe not enough. We need to include also social science, behavioral science, the communication, the perception of the different message. This is important as well. It's about translation. And this has been a very interesting focus. How can it be that we have such technology progress, scientific progress, and that we are not enough able to translate this to the field, to translate it to medicine, to public health, to One Health? We need to design more efficient mechanisms, and in particular between academics and industrials. We need to better define what we call return on investment when it comes to infectious disease. And we can come back to this. We had some interesting conversations on this. We need new models for this translation. And finally, it's about international collaboration. It may sound obvious, but as long as we will have each country trying to cope by itself with the pandemics, we will not come through. It is international collaboration, including those countries where the virus comes from, be Africa, be Asia, obviously China. That means without restrictions, without borders. And finally, we are not just in the midst of a crisis and we say, okay, when the crisis will be over, we will prepare better for the next one. No, it is now. It is now that we must reorganize, improve, and this has been, again, an important conversation during this workshop. The second point I want to take is really preparedness and predict. Can we predict the next one? Because we know that it's very likely that we will have other viral infection and other pandemics. Can we predict? Well, again, we have to be very humble. The honest answer is it's extremely difficult. This is why we have to be ready. There is prediction, there is readiness. So we had very interesting conversation during this workshop You see, regarding coronaviruses, we have 7 coronaviruses. The 4 human coronavirus of the common cold, those we have every winter, and then we have SARS-CoV-1, MERS-CoV, and now SARS-CoV-2. It's very interesting, and this point has been made by some of the scientists, that 5 of the 7 human coronavirus, they have emerged over the past 20 years. So we have a kind of acceleration of this transmission, which reflects changes in the human ecosystem. And also 5 of the 7 came from bats. And we know that animal viruses are the major reservoirs for these emerging infectious disease, not only coronaviruses, and this is a concept of global but also health. And actually, we also know, we have to be clear, that you have other bat coronaviruses which are ready to go, and this is why we need to be better prepared. So I will just take 3 points on this. First, humans are the best sentinels. You see, you have some networks which really aim to sequence all the viruses all over the world, and this will provide a very interesting knowledge. There is no doubt on this, but this will not really predict, because detecting a virus doesn't mean that it will infect, and you have a number of sampling and technology bias. I don't want to go into detail. And so the conclusion was, when it comes to surveillance, we should really focus on those human sentinels which are at the interface between humans and animals. The second point is that the technology, and this will come over and over during this press conference, as it came over and over during the workshop. We have the technology, we have the capacity of data analysis, we have the digital technology, artificial intelligence, we have this. Question again is, how do we apply it to our question? And finally, and this is a controversy that we want to clarify, there is really no scientific evidence for SARS-CoV-2 being the result of human manipulation. And there is a real agreement of the scientists on this. So then comes transmission. Now, we all know this is a respiratory virus, highly contagious, with low mortality. This is unfortunately the best combination for a virus to spread very efficiently worldwide. We all know the importance of masks, of distancing, of also, obviously, of washing hands, also of disinfectants, which are frequently underappreciated. And I just want to take 2 points. One, gathering. You see, it has been re-emphasized during this workshop that, strange enough, only a handful of infected individuals are really contagious. So it really comes to the concept of what we call the super spreaders. Why do some individuals really transmit the virus to so many individuals? We know that they have a high viral load, they are generally young, but not always, and there are likely other factors that we do not control, but we must work on them. But then it comes to super spreaders, to super spreading events and gathering. And it is clear, and it makes sense from a statistical point of view, that if you have gathering, well, we just increase your risk to be with a super spreader. So when we make recommendation, we should never forget that large gatherings are and have been always at the heart of the spread of the epidemics in given regions and countries. And the second point is about aerosols. This is debated, but it is clear that you have short-range aerosols, and in particular in the context of super spreading event, which contribute to the dissemination. Unfortunately, although the masks are very efficient against large droplets, they are efficient, but to a lesser extent, against aerosols. So treatment will be discussed also, but very briefly, we have really discussed the fact that we have been very much working with drug repurposing, which is obviously very important because you can go fast, because you know the drugs, and that you can really, again, screen, and a large number of screening have been made, and some candidates have been identified and so on. But at the end of the day, what the workshop really shows is that we do not have so many molecules. Actually, we have found the steroids, remdesivir, which has only a partial effect. So we really need, obviously, we are waiting for other results, but we also need to have in parallel a drug discovery program, which takes longer time, but which is still very important. So I don't want to spend too much on this, although this is very important, but at the end of the day, we had several presentations on new potential therapies, which are still at early stage. It will come on drugs which can target multiple pathways, combination between antivirals and immunomodulatory molecules. And we had also presentation on the early stage of trying to drugs which would have a broad spectrum antiviral. Is it possible in the future to design drugs which are not directly the antivirals, but which impact the cell and which can be, for example, helpful both on coronavirus, but also filovirus, influenza, and so on. The antivirals should be used in the very early phase of infection, because afterward, it's really about inflammation and immune modulation. And the conclusion of the workshop is that really we need to work better on an understanding of the natural history of this disease. We need a lot of this, both a combination of basic and clinical research to decipher which is this natural history if you really want to be very efficient. Diagnostic is at the heart of the control of infectious disease. This point will be taken later on, but I just want to make this point. First, how can we be still using nasal swabs, very invasive, while you have salivary tests? How can we still use a good test, PCR-based? I'm not telling that they are not working, but the workshop really emphasized that we have now rapid molecular tests. We have point of care. We can give the results in 1 hour with a low cost. Again, we can use salivary tests. We need to translate better to the diagnostic, the progress in technology. We had very interesting session on the serologic assays, and this will be addressed by the experts, which are important not only for diagnostics, not only for an appraisal of the epidemics, but which are very important also for understanding the correlate of protection. What does mean neutralization? How long does it last? And by the way, there were very interesting presentation on the comparison between children and elderly, which really explains why this is important. If you compare the antibody profile of an infected child and an infected elderly, both are antibodies positive, but the nature of the antibodies is very different. And this may account for difference in the severity of the illness and possibly also contagiosity. Finally, vaccines. I mean, we are obviously, all of us, hoping for vaccines. We had, again, very good sessions on this. First, we have many candidates. We know this. And the aim of the meeting was not to compare and to describe all of them. Let's be humble. We do not know which vaccine will be the first to work. We do not know how it will work and for how long. So we have to be very careful. We had presentation on the safety issue. We need to ensure safety, which means also proper animal models, which need regulatory issues, and we had presentations on this. And you see, we know that about 50% of the American citizens don't want to take the vaccine. And it just holds true also in Europe. We cannot afford having side effects. We must ensure safety. We will have vaccines which will appear. They will generate antibodies. This is all very good. But we will have to know whether this is really protective, for how long it is protective. And again, we will need to rely on very solid science. It is likely that we will have second generation vaccines more focused on cellular immune response. But then comes the innate immune response. And you see a lot of focus has been paid during the meeting on the impact of the innate immune response, this first line of defense, which is not specific for a virus, but which is key in the defense against the virus, and the possibility to have non-specific immunization. We know, and we had very good conversations on this, that BCG or oral poliovirus, they have been demonstrated, in particular in Africa, to prevent not only tuberculosis or polio, but to decrease the overall mortality, for example, in neonates. So the question is, can we use this approach for COVID-19? And this is really a very important avenue, I would say, very complementary instead of the specific vaccines, and which could bring a bridge. So to close, I would say that this is a summary. We will go in more detail. At the end, we have major challenge ahead. I want to come back to what I said at the beginning. It's not a crisis, it's a new era. We need a new organization. We need it now. We do not need it in 1 year to prepare for the next pandemics. And this is really where networks are very complementary to the existing research institutions. And this is where the Global Virus Network is really very important and again, complementary and not at all redundant with the national and international agencies. We have many networks and we need to coordinate and to really have these networks work. So at the end, the major suggestion of the Global Virus Network scientists during this meeting has been really to create what we would like to call the Viral Pandemic Readiness Alliance, the Viral Pandemic Readiness Alliance, to really merge the efforts, because this is a fight which is going to last, and we have to be accountable because we need to find solutions all together. So I will stop there, Lisa, and now we can take some questions.
Wonderful. Thank you very much, Dr. Brichot. And let me start with this question, which really follows up on your excellent summary. You've talked about the alliance, which is assembled. I wonder if you can describe in more detail 2 or 3 significant and specific takeaways that the alliance has gathered over the past 2 days that could have an impact today and going forward on how the world is coping with COVID.
Well, I would say that, for example, what we have, I could take actually many examples, but I believe that the coordination, for example, on how to understand the natural history, how to combine clinical studies and animal model. This is an example where joining forces, you see, because you have several animal models of the infection. Which one are the best? They do not necessarily always recapitulate everything. You need also clinical studies, you need cohorts. So this is an example where merging, you see, the forces worldwide can really provide information. You see, when you get information in the US and you compare to information obtained in Australia, in Africa, well, you have individuals who have a very different environment, including nutrition, which is very important. So that's one point. The second is about vaccines. You see, this is really something where we will need to join forces to provide expertise on what's going on, which are the directions to be taken. Finally, I could have taken others to answer your point, because there are several, but I would also take the diagnostics. For example, how are we going to translate the point of care, the new serologic assays to developing countries? You see, not only to the Western and so-called developed countries, but how are we going really to provide the world, I would say, with the progress of science? Well, this is something that you can achieve with networks like as the Global Virus Network.
I understand that. And I have a follow-up question, which I don't intend to be a political question, but it is this. in a perfect world, which this is not, what role would the World Health Organization be playing, or should it be playing, to collaborate or encourage the collaboration that you say is important going forward?
Okay, I have my points on this, but because I don't want to speak only me, I would like to ask maybe Ab Osterhaus to take this question. Now you are on mute. You are on mute, Ab.
Sorry for that. Could you repeat the last part of the question?
Certainly. It's asking you to take a look at the World Health Organization and explain to us what role it should play, if it isn't already playing, in accomplishing the cooperation that Dr. Bréchot just described as essential going forward in attacking the COVID pandemic.
Yeah, so basically there are many tasks that the WHO should be doing and to a large extent is doing. And I think it starts all the way to the early warning systems. So when you really talk about new things coming up and really having a role in alerting the world for something new, and then of course it should play quite an important role in all the different intervention strategies that come at a later stage. So basically, you start with the early warning system, which is basically they're not doing that alone, but they have to coordinate that. And I think it's important that realize that we are dealing with an independent organization there that would be well placed to do that. And as soon as there is something new coming up, and we have seen them acting during not this pandemic, but the previous pandemic. And then there was a lot of confusion there about what is the pandemic, what are the stages of a pandemic, how are we dealing with that. I think that's quite difficult a role for them to play. And I think it's important that whilst they are really looking into alerting the world and really giving messages. So during this pandemic, for instance, we remember that already very early on, there were messages coming from China. China actually stating very early on, already in January, that there was transmission of the virus even before symptoms appeared, which is quite important, which really from an epidemiological point of view, really sets this COVID story completely apart from SARS in terms of how it could spread, etc. Well, at the very beginning, that message was not very clear, although very rapidly thereafter, the WHO, the let's say Director General actually state quite clearly that this is the case, and then of course is mobilizing all the means we have worldwide to create intervention strategies. And I think it's quite important to have an independent body doing that, where indeed they can call upon all the member states, all the experts they have in all the different countries that actually deal with this particular situation. And this very early on, I mentioned communication, which is quite important, obviously. And after communication is really how to coordinate intervention strategies. The most important thing, as Dr. Bréchot said already, is international collaboration. And so it's very important to characterize the virus, to follow the virus, exactly what it's doing. And then we have all the other efforts that were mentioned and were also being discussed at the meeting of developing antivirals, developing therapies, but also developing vaccines. But even before that, it's having the right technology to diagnose the disease, to really get a grip on it, how far is it spreading, what does the epidemiology look like? And then you get this all these different things that deal with intervention strategies. And I think the role, they should be a coordinating role in all these different things. And then perhaps the last point mentioned, and there's much more, it's it being an independent organization, they can call upon different groups to collaborate from different continents, from different countries. And then I think it's quite important that at the end of the day, and we haven't faced that problem yet in this particular pandemic, but equitable distribution of not only the diagnostics, but also let's say the medicines, but at the end of the day, the vaccines also. So we know there's a lot of vaccine initiatives ongoing, and what we need to see at the end of the day, that we have in principle and ideally a vaccine available for more than 7 billion people. So basically they have a coordinating role there as well. So that's more or less a global overview. I think it's quite an important organization, and if it functions well, we will benefit from it all.
Thank you, Adam. Thank you very much.
I wanted to double back, Dr. Brichot, on the point you made about children as against the elderly and their profiles, and whether you think, or the group thinks, that has any implications worldwide for the reopening of schools, which has been such a controversial topic, with obviously risks and benefits on both sides. Can you offer some observations about that?
Maybe Lin-Fa Wang can make a comment on this.
Okay, so thanks, Dr. Brichot, and thanks, Lisa. To me, this is a complicated issue, right? So children, the policy about children right now is not only about whether they have a different immune system and whether they will become sick. So this is being debated by itself, right? You know, they have a less chance of have severe disease, that's for sure, but it's not zero risk. Okay, so that's number one. Number two now is more important is what role they play in the transmission. Okay, so we had, sad evidence in the USA, you have teenagers go out to party and come back, transmit to parents and dies. So in the school situation, this is also very, very complicated because that it's not only about the children, it's about the role they play in the transmission of the whole society. So for me that, until we have a better understanding of, or we have a very proactive still monitoring and sort of a system in the school. So school can be opened, but we still have to monitor. It's not to say they're 100% safe, and also to say there's no risk to the society. So that's maybe I just add to these 2 points. Thank you.
Thank you, Lin-Fa. And yeah, that was a general agreement that this monitoring and understanding, I would say, are associated to precautions, then allow this opening, but with this monitoring again. Thank you.
Great. Thank you very much. A question about the vaccines timetable. And I recognize your humility in saying appropriately that you don't have a crystal ball. I'm paraphrasing, but realistically, many people, certainly here in the United States and around the world, are hoping for some sense of timing about when a safe, effective, readily available vaccine might be available so that they can resume some of the big gatherings, whether it's holidays or theater offices or mass transit, that they're comfortable doing. And your best estimate would be perhaps not to give one, but I can't resist asking.
Sure. Maybe Konstantin Shumarov can take this question.
Yes, thank you for the questions. I think it's on everybody's mind. Everybody wants to have a vaccine yesterday. But unfortunately, we're doing our best. I mean, the scientific community and regulatory community normally it takes years to develop vaccine. Right now, many vaccines are in the final phase of clinical development, tested for their efficacy. So in theory, if everything goes well and the phase 3 study will complete and demonstrate that the vaccine is safe and effective, then of course it can be used. And like you say, I don't have a crystal ball, but based on the timeline of the clinical trial, that could happen sometimes even later this year or maybe early next year. Again, if everything goes well. But there are many potential problems here because number one is safety. We need to test in a large number of subjects to make sure that the vaccine helps and does not really hurts, because we're giving it to healthy people who expect to be protected, not hurt. And second, of course, it should be effective. And we will not know how long this effect will last, protective effect. It will take perhaps more time, even after licensure and after the vaccine will start being used in general population. So there are a lot of issues. The most optimistic, projection is perhaps sometimes later this year, but maybe it will be later.
It may be optimistic, but thank you very much, Konstantin.
We must remain optimistic, but of course, being a realist at the same time.
Yes. Thank you very much.
Dr. Breshow, back to you to follow up on your observations about masks and aerosolization, and if masks work partially, but maybe are not efficacious across the board. Do you have a view about whether people should wear face shields in addition to their masks to protect themselves?
Well, it's a tough question. I believe that there is some evidence that it can be efficient, but I believe that it should not, at the end of the day, mask or whatever disposal will not be sufficient. You need to combine this with social, I'm sorry to repeat obvious points, but it's about distanciation, it's about washing hands, it's about disinfectants, it's about avoiding gathering. So you see, yes, there is some evidence for efficacy, but at the end of the day, the point is to combine these measures, you see. There is no miracle disposal. That would be my answer.
I wanted to now go back, and perhaps some other panelists can weigh in on the relevance of your assertion or your finding or the general agreement in the community that this epidemic, the virus, was not created by a lab, was not created by humans. And I wanted to ask you to expand on that a little bit, and then maybe talk about why it's so important that the general population understands the origins of this virus and is understanding that there are false narratives that are being propagated, why it's so critical that people understand where it comes from.
Yeah, I will answer, but maybe this point will also be taken in the second part of the press conference, in the conversation between Bob Gallo, Dr. Robin, David Sher, and myself. But no, to your point, this comes from sequence analysis, extensive sequence analysis by experts. So it's really science-driven expertise. Why is it important? Because, as you said, we have a very complicated situation. So, well, we need to work on facts, you see. So, and so we just need to avoid fake news and controversy which are not science-driven, which are not public health-driven, but which stem from different agendas. So you see so we don't want to provide interpretation. You see, the Global Virus Network is just to make a statement. That's the way it is. Doesn't mean that we do not have other hurdles in the way the epidemiology has been disseminated. Doesn't mean that there has been no mistakes, but just a fact. There is no scientific evidence for a human-made virus, and that's all. And in general, we need to have expertise, science-driven, independent. This is a good example.
Yeah. Thank you. Let me ask another.
Christian,
please.
Sorry, perhaps Christian, might be good to ask Limfa. Yeah, because he has been doing a lot of that sequencing and then giving a little bit more of the detail. Yeah.
Yes. Okay. Yes.
Yeah. Thank you, Lisa. So I think two questions basically you're asking. Why we're so adamant to say this is not man-made virus, and secondly is why it's important to get to the bottom of the origin of the virus. So this is really, I was going to comment when you asked, whether WHO is playing a role. If not, should they do better? And I really like to, go back 17 years ago when we had the SARS outbreak. The geopolitics was very different. I mean, Abba was on the committee. We have a network and we have almost a daily conference call, data sharing. And I got into this at the last bit, is when the pandemic was already under control, we did not know where the origin was. At that time, there was also conspiracy theory from a military sort of a weapon laboratory that was leaked out. So it's very important, but it's a very international collaboration. The mission to China to investigate specifically the origin and early transmission event has 1 American scientist, 2 Australian, 2 French, 1 Japanese, 1 Filipino. So, it's totally transparent. Everybody knows who are on the committee, where they're going, why they're going, who they're meeting, what they're investigating. And today, we had the 2 WHO representatives went to China. It's not public, and we even don't know. So the politics really is very different this year versus 17 years ago. Now to the science. The science is that, as Dr. Brescher already said, there are so many evidence to say it cannot be a man-made virus. I think I just gave you a number because the closest bat-borne virus, the Wuhan Institute of Virology, my former student, did. I was in Wuhan January 14th, actually, so I contributed to this Nature paper. 96% identical to the human SARS-CoV-2. Now, for general public, that's very close. So why can't you just make that 4% difference into SARS-CoV-2? We're talking about a 30,000 nucleotide difference. 4% is 1,200 nucleotide difference, genetic code. Each genetic code has 4 possibilities. So you had 1 out of 4 in that one position, and to the power of 1,200. So I always say that if I have all the money, not only medical research, all the research money, the top virologists all work for me, I will not be able to make it. So scientifically, just impossible from existing natural virus to make this man-made virus. So that's my really sort of point. And then there are many, many sequences now, bat-borne viruses, and I'm very confident with the international collaboration, it's a matter of time we'll find the origin. And without being political, that's where also the international collaboration is very important. The cliche says virus recognizes no borders. I'm going to add on, bats recognize no borders. Wildlife animals recognize no borders. Other they did not recognize, or the illegal trading would not recognize borders. So I think, in my field, we are right in this field. We are all really try to, put a petition in, let's collaborate. We will start from Southern China, we go all the way to Southeast Asia, and we will do a very detailed analysis, non-political and scientific only. And I think this is really important because we have to know the origin so that we can prevent future transmission event. And in that process, I can guarantee we will discover SARS-CoV-2 related viruses. It could be in Southern China, it could be in other nations, so that we can really intensify the surveillance and prevent the next pandemic. If we cannot prevent, at least we can do much better in early warning and mitigation. Thank you.
Thank you, Linfa. Lisa, I would like to ask if you agree, because time is passing. I would like to ask to our 2 experts on treatments. I mean, maybe their opinion, and maybe starting with Ray Skinazi. I mean, Ray, can you comment on the results of on the present situation regarding therapies? Which are for you the major challenge ahead for treatment?
Thank you very much. And I think we really are in the first quarter of this battle. And right now, the virus is winning. Let's face it. But I don't think that's going to last very long. We just need a bit more time to find antivirals that can be used, especially in outpatients, what I call outpatients. That's where the real need is going to be. People who are, to explain what I mean by outpatients, those of you who are not involved in clinical medicine, is really the patients that come to the doctor. They basically have lung problems, but not too strong, nothing very strong. They have diarrhea, they have a high temperature, but the doctor just doesn't go home, take some Tylenol, and come back and see me when you have serious lung problems, and then I will put you in a hospital. So we need something for that, and that's quite urgent. We also need, of course, drugs prophylactically, which can be used, for example, before you take, like we do with malaria drugs, and also with Tamiflu, for example, and Baloxavir, which are used for influenza. They all can be used prophylactically before going on a plane, for example, before entering a movie, before having a large gathering, for example. And then, of course, there is the moderate and severe cases. There, antivirals will do very little unless we find that these antivirals have also anti-modulatory, immunomodulatory effects as well as antiviral. So it depends, the antiviral situation, it depends on what stage of disease you are. The biggest potential is actually outpatient, in my opinion. And actually, there's been absolutely no studies in outpatients that I'm aware of in terms of antivirals, even with remdesivir, for example. Hopefully, these studies will come, or baricitinib for this matter. I wouldn't give steroids, but I would definitely look into remdesivir. Unfortunately, it's an IV drug, and they're talking now about aerosolized remdesivir. So that could be an option. We still don't know that. So that's related. So it's all related right now to disease stage, and that's very, very important. Early, very early, or even non-existent. How do you protect yourself with an antiviral? And I think we can do that, and that's where the biggest potential is, in my opinion. Of course, the urgency. Somebody who's on a lung machine is a different story, and we have to do something more drastic to make sure this person does not die. So this is the first point I want to make. There's been a paucity of effort funded by at least the US government on antivirals, very limited. It's usually jointly with a company. I understand the government wants a rapprochement with industry, and that's great. But if you look back, a lot of the drugs actually come from academia. So don't forget there's academia, biotech companies, and also the big pharma. So clearly, a partnership is great, but the basic science, tremendous effort in basic science is coming along, and we're capitalizing on this. Again, it requires funding, sufficient funding. And that's another thing that the GVN has done and will be doing in the future. We're putting a lot of our eggs in one basket, vaccines. And we've seen, for example, with hepatitis C, we've never been able to get a vaccine. What we have been able to do is find drugs that actually not only treat, but also cure the disease. And that's what we should aim for, a curative therapy. And I think there is effort in this area, but again, it's going at a slow pace. So I'm concerned about that, and Dr. Brichot mentioned that earlier. We really don't know if any of the vaccines are going to work, and I would hedge my bet by having some efforts in drug discovery and drug development. We put too much effort on repurposed drug for the obvious reason that we want to cure rapidly. And again, we're having some success. Remdesivir, for example, is a repurposed drug. Baricitinib is a repurposed drug that was used for rheumatoid arthritis. And steroids, of course, everybody knows about steroids. They're used worldwide for everything, for every ache. There was tremendous promise, of course, with this type of steroids. There are many types of steroids, but they're not really that specific. And actually, the studies that have been done are not really proper studies, controlled studies. So again, I'm going to go back. The important thing is to do properly controlled studies, not necessarily placebo-controlled, because we now have drugs that do work. They don't work very well, but they work. And looking at combinations may be the way to go. I don't think there's many studies of remdesivir with another antiviral agent, for example, a true antiviral agent. But a remdesivir, again, is not an optimal drug for various reasons, but especially because it's IV. And for outpatients, you will not be able to use it, as I've said before. So I'll stop here. You can take some more questions.
Thank you, Ray. Thank you very much. Unfortunately, time is running as always, but I would really like to conclude with asking Johannes to provide maybe a concrete example of how he sees repurposing. As Ray has just explained, we really have both repurposing and drug discovery, and both are very important. Johan, maybe you can make a comment on this.
Yeah, thank you so much. I think it's indeed important that we have drugs. I fully agree with Dr. Shinazi. It's a pity, I mean, that at the time that the virus exploded, that we had nothing at hand and that we had to look into repurposing drugs. I can just tell you that within a couple of days, we will come out with a paper in the Proceedings of National Academy of Science of the USA, PNAS, in which we report that a Japanese anti-flu drug, film Fujifilm, And they came out yesterday with information that this drug is working also in patients with SARS-CoV-2. So it's shortening the disease with 4 days. So we used a hamster infection model, and we do show that it works quite efficiently, although only at very high doses. But to come back to what Dr. Shinazi said, if we have a model in hamsters where we have transmission between two animals, so we put an infected animal together with a sentinel, and we treat the sentinel prophylactically with the compound, the animal does not become sick. And this is indeed something that may be quite important, for example, in household contacts and doctors and nurses working with sick patients. Now, my point is that, and I again agree with Dr. Shinazi, that we are in this interface between, in January, the virus popping up, and somewhere in 2021, the first vaccines becoming available. In this interface, we have nothing, we have no weapons to battle this virus. And that's sad, because we know, as Dr. Shinazi also said, that you can develop highly potent drugs, and hepatitis C, for example, is indeed to which you made major efforts, Ray, is that you can cure hepatitis C, chronic infection. You can just cure it for 2 or 3 months with highly specific antivirals. So we have 30 drugs, highly efficient drugs against HIV. So the point is, you can, against every single virus, develop drugs. And so we could have had, so as you mentioned, Christian, we knew before December 2019, we knew 6 coronaviruses, 4 that cause mild symptoms, and then SARS-CoV-1 and MERS, and MERS. So we could have had, and we have been doing some efforts on that, could have had a pan-corona inhibitor that could have, for example, been stockpiled by the WHO. This should have been a compound or compounds, multiple drugs perhaps, that could have passed, should have passed phase 1 clinical studies, should have shown safety, at least an efficacy in animal models. But then imagine that in January, at the time that you had the first patients in Wuhan, and it was identified that this was a coronavirus, then the WHO could have sort of shipped such drug. If they would had it on a stockpile, they could have shipped it to Wuhan. They could have treated sick patients to reduce transmission. You could have treated nurses and doctors to protect them. You could have treated household contacts, and together with quarantine measures, you could have perhaps stopped this outbreak and had the situation as in 2003 in Hong Kong with SARS-CoV-1. So my message is that we should, not only against coronaviruses, because other viruses or other families of viruses may also yield potential pandemic candidates, we should, at least against a number of these families of viruses, coronaviruses, bunyas, paramyxos, and others, have some highly potent drugs ready that can be used at the time that there is a little outbreak that has that has a potential to become something big. That should be a weapon that mankind has to stop an outbreak of a novel, unknown virus from the very beginning. And that's my message.
Thank you so much, Johan. So, Lisa, I believe that we will stop there this first part of the press conference, but I really believe that both the presentations and questions and answers really illustrate why you need to be comprehensive, to have a comprehensive vision, and also an international vision. And this is really what the GVN and the Viral Pandemic Readiness Alliance proposal is about. Thank you very much to all the panelists.
Yes, thank you. Thank you, Dr. Brichot. This concludes the annual meeting summary presentation, but coming up immediately thereafter, we have an exciting conversation with Dr. Bob Gallo, who's the co-founder of GBN, and Dr. Eric Rubin, who's the current New England Journal of Medicine editor, and Dr. Brichot. David Shear, turning it over to you.
Here?
Unmute.
Okay, perfect. Well, good morning. My name is David Shear, and I've been a serial entrepreneur in the life sciences, including companies and antivirals, going on 40 years. And I'm very honored to serve as a moderator for today's fireside chat. In my not-for-profit activities over these years, I've had the opportunity to work with some of the leaders in public and global health. A significant amount of my experience was gained through many years of work with the Harvard T.H. Chan School of Public Health, which is a principal affiliation of one of our speakers, Dr. Eric Rubin. In those years, I partnered with researchers and faculty on initiatives involving malaria, HIV, TB, and cancer in the developing world. I've also chaired a series of global health conferences at Yale and currently on the advisory board for the Rutgers Global Health Institute. More recently, during the coronavirus pandemic, I've chaired a coronavirus bioscience task force in Connecticut and served as a member of the Reopen Connecticut Advisory Group, which provided our governor with the framework for the reopening of our state. I recently joined the board of directors of the Global Virus Network, which has arisen from a relationship that I've had for 40 years with the other speaker in the fireside chat, Dr. Robert Gallo. Let me start by doing some brief introductions of our two principal speakers. You've heard, of course, from Dr. Brichot, who's an extremely esteemed and accomplished leader in this field as well. Dr. Eric Rubin. Eric is the chair of the Harvard T.H. Chan School of Public Health's Department of Immunology and Infectious Diseases, and the Irene Heinz Gibbon Professor of Immunology and Infectious Disease at the school. He was named editor-in-chief of the New England Journal of Medicine in June of 2019, following a 7-year stint as one of its associate editors. Dr. Rubin is an esteemed scientist who has focused much of his research on Mycobacterium tuberculosis, the pathogen that causes human tuberculosis. He's the author of 147 scientific articles. Dr. Rubin brings an extraordinary perspective to any discussion on global and public health and pandemics from his years of academic work in the field of infectious diseases immunology. More importantly, the work that he and his colleagues at the New England Journal do every day provide a near continuous stream of high impact publications, as well as commentary to enable a fuller appreciation of where we are and where we're going with the COVID pandemic. The next person probably doesn't need much of an introduction, but there may be some elements of Dr. Robert Gallo's background that might be of interest to some people. Bob is one of the most celebrated virologists of our time. He is the co-founder and director of the Institute of Human Virology at the University of Maryland School of Medicine and the Homer and Martha Gudelsky Distinguished Professor in Medicine. He's also the principal co-founder and international scientific advisor for the GBN. Few people may be aware of the fact that Dr. Gallo, beyond the discovery of HIV, also had discovered a factor which was absolutely instrumental in terms of the cultivation of the virus. And that was something that was called T-cell growth factor, but more recently, interleukin-2 or IL-2. The same molecule that Dr. Gallo and his colleagues had discovered has actually been shown to be a breakthrough for the treatment of a number of otherwise intractable cancers. Discovery of HIV was only the first step in tackling public and global health threat that the virus posed. There was a need for a sensitive and specific diagnostic for the blood supply, which was initially one of the major sources of transmission beyond sexual contact. Bob and his group developed the first highly accurate HIV blood test. And clearly that work gave rise to serological assays which are used routinely today to determine if an individual is infected. These activities alone are responsible for saving countless lives. His pioneering work in HIV was also critical in the development of drug discovery platforms that gave rise to direct-acting antivirals that have transformed the diagnosis of HIV from a death sentence to a condition that is almost as easily treated chronically as diabetes. He's the recipient of many awards, including 2 Lasker Prizes, and by some counts, in excess of 1,200 publications during his career. His mission in the founding of the GBN in 2011 was to launch an organization consisting of some of the best scientists, researchers, and institutions focused on virology and infectious diseases, in order that we as a society were, and I'm going to quote, organized and better equipped to deal with the new and existing viral threats. There can be no more timely mission that was the basis for that formation of GBN than what we currently face. And thus, Bob brings a special perspective to the discussion we're going to have today. We're going to have 2 blocks that will be divided by short 10-minute question and answer sessions. What I'd like to do is actually start with a question directed to Eric. And the question is, how does this current coronavirus pandemic and the response from the world compare with some of the preceding pandemics and public health crises involving viral infectious diseases?
Thanks, David, and thanks for inviting a lowly bacteriologist to a virology conference. It's really an honor. let me talk about how the previous pandemics have started and ended. Let me give 3 examples. The first, of course, is the 1918 flu epidemic that a lot of people have drawn as a comparison. That one started, as all flu does, in a seasonal way, and it ended, again, because of the seasonality of flu. That, together with the fact that people who'd been previously infected were protected against disease, and that brought an end to that round of pandemic flu. Of course, there have been subsequent pandemic flus that haven't risen to that level of severity. Ebola, we've had several Ebola outbreaks, including the very large one a few years ago in West Africa, and the one that appears to be ending now. And that disease has been controlled by public health measures largely. Until recently, we didn't have any specific interventions. What we did is we contained it by quarantining and isolating people, the same sorts of measures that we're using now. And that was pretty effective. Adding on a vaccine, which we have now, is certainly enhances the efficacy of those. But again, we're able to control those outbreaks. The last one, though, I mentioned is HIV. Obviously, this is Bob's area of expertise. HIV still hasn't been controlled exactly. And part of the problem with the HIV not going away is that there really isn't much absolute resistance to infection. And so most people, when they get infected, almost everyone will go on to develop disease. And there isn't the sort of immunity that we hope for other diseases. And as several others have raised, it's been very difficult to develop a vaccine. And the way that the epidemic has been controlled, or contained, if not stopped, has been with using largely drugs, as Christian mentioned in the last session. So I think every pandemic is a little different from every other one, and it's difficult to know what's going to end this one. We'll see.
Well, thank you, Eric. I'd like to segue to Bob. It is sort of maybe not ironic that back in the days of HIV, diagnostics played such an important role. Can you give us your perspective, taking us back from HIV to today with coronaviruses, what the role of diagnostics has been and needs to be today and in the future?
Sure, I can do my best. The epidemics and public health angles have several things in common. But as Eric just mentioned, as he finished, that every epidemic or pandemic is different. And there could be no greater difference in the kind of viruses the two are. HIV and AIDS was mysterious. The virus was not easy to find. Proving causation of a disease that took several years to manifest itself was not easy, particularly when the disease appeared there were so many other infections, which one was the cause. So it presented very different problems, and it was not easy to catch. As you know, it requires biologic fluid. The first thing, and I have to say, the passion of getting the blood test, we were driven to, not primarily by public health concerns, actually. I mean, it certainly was in our mind, but we were driven to realize that verification comes from confirmation and gives the credibility. We felt strongly from a lot of virus isolations that this was the cause, but we wouldn't be able to pass that technology readily to other people. They weren't used to growing T cells, for example. Retroviruses we had experience with in humans from recent discoveries of earlier retroviruses just a year or two before. So we were in a very good position for this, lucky position. And we really wanted to make this confirmed all over the world, and that would be by a blood test. So we were driven by ideology. How can we get other people to confirm this with massive serology? And so we pushed forward on it. And I remind you, we were at NIH, not CDC. That's a reminder for me to say, I'm always puzzled by how this became a CDC fault that we don't have a blood test. It's all our fault. Blood tests come from academia. They come from NIH. They come from CDC. So we collectively didn't get a blood test. It's not just CDC. So now to get to your really issue, David, you want to know what this did for us in in public health? Well, first of all, in a disease that you have to wait years to see that the person has AIDS and therefore is virus infected and probably actually spreading the virus, you'd sure like to be able to diagnose it early. And so from a few weeks after the person gets infected, we now could say that guy or gal is carrying the virus. So that made a huge epidemiologic difference and allowed people to know how many people had AIDS or AIDS about to come. And soon we learned that over 99% of infected people will get the disease and die of their disease. So this was absolutely essential to predict the epidemic, to predict the disasters that we were facing, and subsequently to know, obviously, who to educate, who to treat. When we learned, just like other human retroviruses and animal retroviruses, it also transmits mother to child. So we would know what mothers to be educating. We would know what people to say, please lower your sexual activities, to give them as much education as possible. And when therapy became available to treat the disease. Without diagnostics, without a good test, you go nowhere. For me, it's as, sometimes more important than a vaccine. What we heard at the meeting, for example, and I'll close with this, there's a very rapid diagnostic test. Jesus. Nothing is needed more than a rapid diagnostic test. What we heard described by some people at the meeting of a molecular test that can be done cheaply and maybe at home and maybe within 2 hours or less in time. You've mentioned things like that, David. Nothing could be more valuable. We need to be able to trace, right? We need to be able to follow people. We need to be able to educate people. We need to be able to follow the epidemic. This is absolutely basic, and without it, we can do nothing. So there's singularly nothing more important in my mind than having this kind of diagnostics. It's not as sexy as some things. It's been on those TV gatherings, usually with controversies and criticisms, but we really have to have it. And it's the responsibility, not just of CDC. It's our responsibility collectively. I hope that's what you're getting at.
Yes, thank you.
Right.
Let me turn the next question to Eric. We've had a lot of discussion throughout the couple of days for the GBN annual meeting, and even in the previous part of the press conference on vaccines. And of course, it's on everyone's mind. Very recent data have been coming out that reflect the fact that there are some emerging new strains. And the question that comes to mind here, Eric, is are these new strains going to play a role in enhanced virulence? Will they have some impact in terms of durability of protection for some of those vaccinated? And if we do have a vaccine, will it be more like a seasonal flu vaccine as opposed to a vaccine that can really be curative, one shot without additional vaccinations?
So you're asking for a lot of speculation here because we don't have a vaccine, and what its performance characteristics are going to be, we don't know yet if there is one that works. Thus far, the changes in the virus, and I'm surrounded by virologists, so I want to say this very carefully, haven't seemed to have affect virulence or transmission. We haven't seen changes that have produced in an epidemiologic sense new waves of transmission or new severity of disease. So I don't think these changes represent anything other than what's called drift, some random changes in the viral genome which aren't of that much significance. Now, they could become significant if we have vaccines that require that proteins be highly conserved. We don't know that yet, and we'll see. Right now, there's very little pressure, evolutionary pressure on the virus to change because we're not taking very specific countermeasures. But once we start taking those countermeasures, there will be selective pressure on the virus, and it will be possible that we'll see escape mutants that are no longer well neutralized by, say, antibodies or T-cell responses induced by a vaccine. We'll see.
I have a follow-up for you, Eric, and that is, there's been a lot of controversy even in the past 24 hours about whether we need a full 2 months of follow-up for safety purposes for the vaccine, for these vaccine trials in connection with regulatory approval. what are your views, or how do you see, this particular situation in connection with, making the case to the public that this is a safe vaccine these are safe vaccines when and if they come to market?
So safety and efficacy go together. If you ask what's more important, safety or efficacy, it's like asking which is your favorite child. You need them both, and but neither of them has to be perfect. It really depends on what we're looking at. Let's take another example. If you look at Ebola, for example, a deadly disease, and if you're looking at healthcare workers taking care of Ebola patients who are at very, very high risk of developing disease, then a vaccine that's protective is very important. And if it has a few side effects, you probably are willing to take those. The difference here is we're vaccinating a large number of healthy, low-risk individuals. And so we need to have a much safer vaccine than we would for that, in that example of Ebola. But setting a precise number on safety and efficacy is kind of hard. It's a balance of the two. The safer it is, the more willing you are to take take a hit in efficacy. And the other way around, 100% efficacious vaccine, maybe we could take some safety. Maybe we could take some trade-off in side effects that some people get. It depends, of course, on what they are and what their severity is. Now, is there a magic to 2 months? No, there's no magic to anything. Is it conceivable that there could be problems years down the road? Sure, it's conceivable. But we have to be practical. When can we start taking a look? And what do we know historically about vaccines and the kinds of side effects we get from them? For the most part, they show up relatively early. And so it's not crazy to be looking at early time points. I'd add, David, though, that, and I think this question came up last time, is when will we have a vaccine? The trials right now are what are called event-driven trials. We need to have a certain number of infections, and we don't know when that's going to happen. And it could very well happen at a time that's late enough so that we have collected a lot of the safety data that everyone would want.
Thanks, Eric. So the next question I'm directing to Bob. The conference has actually had quite a lot of discussion with respect to the role of innate immunity. Perhaps it's the first response, first defense that we have for all sorts of pathogens, including viruses. So there's a lot of interest, and certainly, Bob, you have a lot of interest in the oral polio vaccine as an example, as a bridge until a truly safe vaccine is going to be available for the public. Why has the planned phase 3 for this modality failed to achieve the necessary funding to date, do you think, or do you know? Or Bob?
Yeah, I said that's of course a very difficult question, because I can only speculate about why it's not funded. There are reasons that I would not like to speculate about that I could bring up, and I'm not going to. But in the end, I'm a little bit baffled, because I think it's immediate. You get effects within 2 hours from innate immunity stimulation. That it will work. This is where I had a little discussion with Eric the other day about, I think the evidence now is really at this meeting alone is overwhelming. They'll all work. Any virus that is live and replicating as a vaccine and hopefully completely safe is going to work. It'll give a temporary innate immunity, works for a while, but likely so will this vaccine. I doubt it's going to be long lasting. What we heard yesterday from Dr. Natea from Holland, that that the innate immunity we're learning also gives some kind of so-called trained immunity, and it's lasting more than the 2 months that we were saying. It's lasting as much as 6 months. So there's positive data with measles, mumps, rubella, MMR. There's positive data with OPV, that's the oral polio vaccine, serotypes 1 and 3, because 2 can revert. That's what we want to be distinguished, but this is getting too technical. It would work with probably zoster vaccine. There's no data for that. I would like to see intranasal influenza, which is live, as opposed to the injectable dead one, and to see head-on-head comparison this fall, and my betting is that the intranasal will give some protection against COVID-19. So the innate immunity, I mean, for the people not accustomed to hearing about this, I mean, it's a complex subject. It is the immunity that the invertebrates have, it's the only immunity they have. And we inherited that from them, but we also have the adaptive immune system. And I like to think of the barbarians at the gate, and this is your emergency response to keep them out. That's your innate immune system. Part of it is interferon, which everybody has heard of. So, you know, interferon is actually a big part of it. But there are other things as well. There are things we still don't understand that related to what we call cytokines. There are NK cells that are a big part of it. So you generally stop infections by innate immunity as far as I see or understand. And when they creep through, you then get the adaptive immune system that evolved later, which is more our lymphoid system with antibodies and a variety of T cell functions and T cell responses. So there's been data we heard yesterday, I didn't know the earliest data. It was 1932 in Sweden. I think it was with measles vaccine, where people were seeing, for example, in Africa and in other developing nations that were being vaccinated, and they saw an overall decrease in mortality, a tremendous overall decrease in mortality by a non-specific vaccine. So let's say you were vaccinating against measles, and you saw that the kids that got the measles vaccine, there was a much reduced mortality in life thereafter in the next several years, 50% improvement. And then you look why, and it was infectious diseases. But what I learned yesterday, I didn't know before, Eric, when we were speaking, that they now have honed it down. Guess what all the reduction in mortality is due to? It's not infections in general. It's specifically for lower respiratory disease. So this is highly effective against lower respiratory disease. I believed it wasn't just a gap, although we said that until we got the perfect adaptive immune response, long-lasting vaccines if we ever get them. I believe it should have been plan A. We didn't know it then. I feel this strongly now, that if a new pandemic came along, that's what I'd want. That's what it will give our grandchildren when they visit. That's what I will take now. I mean, one of these. So for me, it's almost self-evident. They're harmless, and they're, in general, as far as the safety record is extremely strong. So what's the downside of this? It maybe people figure that it would ruin the getting out of the classic vaccines that so much is put into, and that is a point. And it is a point to take into consideration. I don't buy anything of safety criticism. That's not a problem. And in something like OPV, why were we attracted to that at the beginning, and why some other people that use MMR are attracted to OPV too? When we have discussions with people that relate to the Gates Institute, they'd like to have it be OPV, but they're working with MMR, measles, mumps, rubella vaccine. And the reason OPV is so attractive is that it's been used for 70 years. Billions and billions of people have taken it. And in a vaccinated population, there's never been one problem, not one single case. In America, between 62 and 1998, it was our vaccine, no problems. In a vaccinated population, never a problem. So what we might worry about is an immune deficient person. But we worry about that with any of these vaccines that are coming forward now. We have no idea what happens to an immune deficient person. So OPV is about 13 cents a dose, a couple of drops on your tongue, tremendous safety record. My old friend Morris Hilliman used to say, greatest vaccine guy probably that ever lived. Start with feasibility when you think of vaccine, not just safety and efficacy. Think if it's going to be feasible. Well, this is highly available. It's very cheap and it's safe. And I think the data from past use of it is convincing. It'll work against respiratory disease. So that's innate immunity, and it's nothing to do with antibodies or T cells, and it's sitting on the shelf. And I think it should be awakening discussion. I think it would be great to see it in some famous journal as a discussion point, maybe among several people, or really get into it in depth with all data presented, and not OPV. the concept of innate immunity is what we should be talking about. So, David, you can stimulate more if you think I'm not answering what you want. You're not giving any guidance, and I think it was enough time that I.
Well, I think you've made a very good case for the fact that it's something that should be studied properly.
Yeah.
Perhaps the question as to why it hasn't gained traction is something that might be not necessarily.
Well, I didn't answer your question. I know I punted on that, but let me say that there will be trials done, for example, a few of them supported by philanthropists in India, for instance. And we were almost there in Mexico, but then they decided, maybe WHO doesn't want the live vaccines around. So, we were puzzled by that. But now Denmark, yesterday's presentation by Christina Stubble-Ben from the University of South Denmark, she's got a study going on OPV in South America. She has another study going in Africa, and more studies to come by Denmark and Africa. So we have collaborators that we're close with. And then there's the people that are associated with the Gates Foundation that are doing measles, mumps, rubella. I don't know where their studies are being done, but they're going to organize a meeting very soon with gathering of various people interested in this concept to get together. If I have any say in it, I'll try to make sure this panel is invited and selectively on this or not. I think it's going to happen within the month because they're acutely interested in it as well. And I think they're getting interesting results with MMR, measles, mumps, rubella. So.
Okay. Well, listen, I appreciate that perspective. I'd like to shift the conversation to what we might call low-hanging fruit. Clearly, we have no guarantees as to when these vaccines will become available and how effective they'll be, et cetera. But what can we do in terms of establishing, in a sense, with tools that may be somewhat readily available? How can we sort of address the problem earlier? And my question, Eric, is, can we do a better job on surveillance testing? This has been a little bit of another one of these controversial topics, but more widespread testing, coupled with the fact that we are obviously looking to develop better therapeutics, rescue agents that can backstop for those who are unvaccinated and or for those, for example, who might not generate sufficient protective immunity.
Sorry about that. I like your analogy of low-hanging fruit because there's a lot of low-hanging fruit out there ready to be eaten, even things that are ready right now that we're not taking full advantage of. And I will point out that using the tools we have right now, which have not included vaccines, and in these cases did not include the use of antivirals, several countries have done a really good job of controlling infection, containing it, and in some cases almost eliminating it. So these tools work, and I think that here in the United States, we've been particularly poor about implementing some of the good public health tools. That's been true in some of Europe as well. We're not the only ones, but it is very acute here. We know that masks work, social distancing, hand washing, all of the quarantine and isolation, all of these measures absolutely work. And they've worked in the US, controlling the outbreak in New York, for example, and having an impact everywhere that they've been implemented. We could do better. And I think your question about testing is a very acute one. I think testing's been given short shrift. It's been easier to build lots of ventilators, I think because ventilators are easy to show. It's easy to show what you got for it than investing in tests. And the number of tests available in the country still is far too few to do the kinds of things that you're suggesting, surveillance, which would be very important. Think about it. If you had a test that cost 25 cents that gave you an answer in 20 minutes, and these technologies exist, and think about what the difference is when kids walked into school and you could test them every day. When an employee came to work and you could test them every day, it would be completely transformative. And a vaccine would help. All these other tools would help. I think the other idea of thinking about other strategies like antivirals as control measures and not just therapies is a good one. That's been wildly successful in HIV. The use of antivirals has decreased the transmission of HIV, not just treated people for disease and saved their lives. So I think it would be nice to have those. Now, the problem is what we have right now, which is remdesivir, is its efficacy isn't great and it's IV, so we can't use it in large populations. I think the idea of developing better drugs is a very good one. Starting from basic science to getting a drug is a very long process, and it would be perhaps unlikely to impact the current pandemic. But it would be great for the next coronavirus to come out. I think it is a good investment to be making now.
Thanks, Eric. Christian, I'd like to direct the next question to you. What do you think the role of industry has been in terms of the response to this pandemic? And I know there have been a lot of very recent questions regarding the transparency, particularly as we're thinking about the clinical data and other data coming out in the vaccine world, and what that impact is in terms of approvals. How are we doing this? Are we doing it well? Are there some improvements we can make in terms of that relationship between industry and public health and governmental regulatory authorities?
Yes, thank you, David. Well, first, I would say that I believe that the massive engagement of industry for the support of vaccine, I mean, from our point of view, is obviously most welcome, because we always have, I mean, we don't know when, which vaccine, but at the end of the day, this effort would never have been initiated without the industry. And Eric was talking, and also Bob, about the Ebola situation. A few years ago, we were in a very different situation. Only a handful of industrial partners were really working on vaccines against this disease. So we are in a situation where I would say that this has been very favorable. And also I really very much welcome the recent efforts of transparency regarding the request for safety, for taking some time, and the consortium between the different industrial partners to focus on this, not only to rush to the target. Now, having said that, to your point, we can really very much improve the translation between the academics and industrial partners on this issue. Be diagnostic, we were talking about diagnostic. This is also a very good example, drug discovery and vaccine. You see, when Ebola came, it led to create the Coalition for Epidemic Preparedness Innovation for vaccine development. And I was at that time president of the Institut Pasteur. And it was really a very interesting, it is a very interesting coalition between industrial partners, academics, governments, large foundations. And obviously they are working very much on COVID-19 for the vaccine. So this has been an improvement. We may need to think about this type of mechanism for diagnostics. You very much emphasize the importance of diagnostics. Maybe we can do better to really prepare for the, not only for the next pandemics, but to really take care of this epidemics, as Eric was describing, by such international, I would say, consortia, to really merge the efforts of the different institutions which are at stake. That's one. The second is that in a much more nimble way, I believe that the Global Virus Network can contribute. You see, this network has been from the very beginning involving industrial partners, and this very much reflects also with your presence in the board and other members of the board. We can, now we have with Bob and with the colleagues introduced what we call the GVN Corporate Center. That means recognizing that the research and development activities of companies, be large pharma, be biotechs, can really be part of the scientific conversation that we have during a workshop, you see. So my answer is we might act at different levels: international, reinforcing such coalitions, much more proxy to the field, I would say, using nimble networks such as the GVN to really get a better transfer of knowledge between the academics and the industrials.
Thank you, Christian. We have one final question, which I'd like to direct to Bob. And it's probably one of the most important questions of the day. And that is, should we be optimistic that we will on a global basis be able to have the current pandemic come under control and be better prepared for that next pandemic?
You're on mute, Bob.
Now I know why you called this a fireside chat. Maybe you should have just said in the fire chat. So, will we get it under control? Well, we have to believe yes, but we don't know that pathway is certain right now. I don't think we're going to be seeing any herd immunity, and I also thought it was a little funny to talk about because I remember once in an interview being told that in San Diego the kids were going to go back to school, and it was very good and wasn't I thinking that's a great step forward. And I just asked him, do the children of San Diego have fathers and mothers and even grandparents? Because, we already brought out, I think it was in the discussion with Eric that, you're going to transmit to people. So, and also there doesn't seem to be strong evidence that herd immunity really does occur in any case. So the answer would seem to be, we have to get the virus infection to a low enough level that the thing just fades out. And how to get it to a low enough level is going to take likely therapeutics, not just the vaccines, which, if we get a perfect vaccine, great. I'm worried about not just the safety issue, but I worry about the durability of the antibodies. If the antibodies are the key things that will prevent infection in the classical or conventional vaccines that are coming forward, because there's suggestions that they may only last about 4 months, and that's something, but that's maybe as good and maybe not even as good as the innate immune system's non-specific stimulation. So I think we'd be chasing our tail a bit if they only last 4 months. I mean, it's potentially doable, but it is going to create some thought problems. So I would not venture a guess. It is possible it'll take a long time, and it'll be years, and we live with it, and it'll peak and go down and peak and go down. That's a horrible, it's not a prophecy, because I don't know. I don't know the answer. So, and I don't want to just make a guess. I'm not optimistic for the immediate future, unless one of the vaccines is really terrific and people really follow things closely. We still don't take things that seriously. We don't really enforce quarantines and things like that. My colleague, even though now in China they don't have any significant problem for a while, my colleague Wei Lu goes to Shanghai and he's quarantined in a hotel for two weeks. We don't have those kind of things in play. So we may have to do more rigid kind of activities like that in order to get this thing eventually totally under control. About optimism about the future and other, did you, David, include future pandemics? Were you also talking about, or just
yes, yes, because that's really the mission of GVN, isn't it?
Yes. Well, of course, we'll face epidemics, and maybe there'll be another pandemic in the lifetime of people in this audience. One wouldn't be surprised if there were not. And if there were, you suspect it'll be another coronavirus or influenza, or X, like HIV was X, or something like the Nipah virus. All of those are serious concerns that we could be prepared for. It's hard to be prepared for X, other than having good local public health strength and good ready-made scientists to work on a problem in consort with WHO interactions. I think I feel that I don't really understand, other than funding, why everything is in the hands of government. I say to myself, what government? Who are we supposed to listen to in the future? You want to listen to the US government? You want to listen to the Swedish government? You want to listen to the Chinese government? So I mean, other than funding and having some responsibility such as CDC, I think we got to work out a mechanism that organizations such as one like this, leading people come together. If you took the panelists this morning and put them as a committee that worked with the entire GVN, for example, you have expertise in every kind of virus, you have them weighing in rather than people wondering, well, we don't know, this is changing, and is this true, is that true? Something has to change. I don't believe this should be left in the hands of government. I think it has to be beyond government. And I suspect we'll be better prepared. We have a good lesson in this, so I think we will be better prepared. I think there are going to be some fights and arguments about how we should have a spokesman for the future and people interacting better. I don't think anybody likes to give up what they control. I think that's going to be a potential problem to allow organizations that have high level people who know what they're talking about be able to be contributing as voice. But I think we need to speak up on it. I think we can't keep quiet about it any further. So, but I remember listening several nights in a row to Governor Cuomo, who I found very interesting and generally on the ball and right. But I don't agree with him when he says we will always remember this pandemic. And that's before it was as bad as now. I don't believe that. Because if you follow the history, you know, Eric, you mentioned the original, the severe flu of 1918. But if you read that history carefully, they forgot the lessons of 1889, I think it was, when there was another big pandemic or big flu epidemic. And if you read Oshansky's book on polio, they forgot the lessons of the flu. And many of us here saw HIV. And I can tell you that in the 60s, late 60s, when I came to NIH, there was a lot of memory of prior epidemics and the importance of infectious disease, et cetera. But by the mid-1970s, departments of microbiology were terminated in some famous American medical schools. And there was a symposium at Cold Spring Harbor in '74, no virus causes any cancer, which was within 5 years to 6 years, of course, shown to be super wrong. So I think we tend to forget it, and it seems to me that every time it's about after 25 years or so. I mean, almost like about a generation it takes, and then people forget. So if tomorrow this thing disappeared, we would remember it next year, sure. And we'll remember it 5 years and 10 years. I wonder about 25 years. Something has to be put in place. And we need the media in that score, science writers, and people not looking and to counter the conspiracy-minded people and give less attention on those things that are social media, which can be useful, I know, but which lead to a lot of misguided stuff. So that's my feeling. We will take lessons from this, definitely, but we have to be, I think, more assertive that are not in governments, and because we don't know what government, if any, are the right ones to listen to. They don't all agree, right? So what government do we listen to? Do we listen to our current government only? Is that where we want to get all our advice? We better be more spokesmen for the future. Groups like this, and not to take over anything, just to know that they are available, and that people shouldn't have to just hear from the government officials, right? I mean, I was 30 years at NIH. I know it well. I know CDC a little bit. I know, but et cetera, et cetera. But I think we have to do better than that. That's it.
Thank you, Bob. Actually, I want to take moderator's privilege here, even though we're sort of out of time. If there are any last thoughts that Eric has, because it's been such a pleasure to have this conversation, and I want to give an opportunity to at least provide any brief final thoughts.
Thanks, David. I think Bob made some very good points about future epidemics. the biggest thing I think we've learned thus far in this epidemic is how unprepared we were and how we didn't have any excuse for it. This is the third beta coronavirus outbreak in the last 20 years. We've been having them every 10 years, and there's no reason to believe that we won't have others. We did not learn the lessons from the previous ones. I hope we learn them again. And it isn't only coronavirus. It's influenza. We're always expecting the next pandemic flu to arise. It's another virus that jumps over from animals to humans. So I think preparation is important. And preparation, there are two kinds of preparation. There's a long-term preparation that GVN has been advocating for. Let's figure out what viruses are out there and what we can do about viruses that haven't yet become huge problems. And then there's when we hear about an outbreak, how can we respond quickly? Clearly in this country, we didn't learn the lessons that they'd already learned in China in the months earlier. So we need to do a better job, and that includes everybody. That includes virologists. That does include the government, because we need to have systems that work there as well. And the general population. How do we understand these things? So I think there's a lot of work to do, and no matter what happens with this one, we've got more coming.
David, I don't want to be the one to close this, that this really should be Eric, but I do want to take a couple of sentences to say, pandemic means all. We need China. We need to be interacting with Chinese medical scientists. They are highly qualified. They have been very open and very good with us in the GVN. I have conversations at least every other week with somebody in China. And it's a great mistake to kind of have China on one side and America over here. It's a mistake for the world. It's a mistake for medical science. And we are greatly indebted to Chinese American scientists who are sometimes now being put into unfair situations with over scrupulousness by some of our investigators and going beyond with vigor any requirement of keeping data in America. We gain. I know in my situation, every patent from a Chinese American scientist came to the United States, not to China. I know we've gained enormously in our institute alone from Chinese American scientists. I think any future preparedness should take into account that we need the interaction with Chinese scientists, and we need fairer treatment for Chinese American scientists.
Thank you, Bob. I want to thank both of you and Christian as well for what has been really a truly engaging conversation today. And I hope this has been a constructive dialogue for people who have been tuning in. And I'll let this go back to our coordinators.
Thank you. This ends the session now. Thank you for all the participants. A recording of this will be available on the GVN website later today.
Thank you very much.
Oh, yeah, good to be with you guys.
Thank you, Eric.
Thanks, everyone.
Thank you. Thank you, David.
Bye-bye.
Take care.
Bye.
That was good.
Yeah.